Hey, I am super excited to have Dr. Desiree McCarthy on with me today. Dr. McCarthy is the medical director for all of Shady Grove in the Atlanta metro area. So I'm so honored to have her. Dr. McCarthy, would you mind turning your sound down just a smidge? We're getting a little bit of feedback.
Is that better?
There we go.
Okay.
Yep. So I'm super excited to have her on today. For anyone who is watching, we're going to be talking about infertility and disadvantaged populations, which means people who are less likely to have access to fertility care and support. That can mean people of color, for instance, African Americans, people who are non-English speaking, people who live in geographically isolated areas, like they may live in the country or live in areas that are a little bit remote and not have easy geographical access to doctors. It may mean populations of people who are disabled or differently abled, who are less likely to be able to access care. So, Dr. McCarthy, welcome.
Thank you so much. I'm happy to be here.
Yes. This is an honor to be able to speak with her. She is nationally celebrated for her knowledge and for her support of families. So this is a real treat today to have Dr. Desiree McCarthy on. So for anyone who's watching us live on either Facebook or Instagram, please type in your question and we will attempt to answer it on the air. And if we can't do that, we will answer it after the fact and make sure that we get all your questions answered. Dr. McCarthy, if you guys scoot over just a smidge.
This way?
Yeah, that is perfect. I got it right in the center. So, yes. So at this point, we're going to go ahead and get started. So tell me a little bit about your practice. If you have tailored your practice to kind of focus on different groups, or if not, tell me a little bit about why some groups have a harder time accessing infertility care compared to the general population.
Well, we're in Atlanta, as you mentioned, and SGF Atlanta, we have a very diverse practice. So we see patients of all backgrounds, whether it's ethnicity, socioeconomic, career-wise, social status. What we learned from our practice is that infertility does not discriminate. So there's no prototype for the infertility patient. And that's my main message to everyone. For a long time, particularly Black women, we have been stereotyped to just not be fertility patients and to not have infertility. So we've just really not been a part of the conversation for a while. And so the bottom line is that anyone can have infertility. Especially important for us is that we do see higher incidence of infertility in African American women and lower income women. And so there was always this perception that we didn't have issues, then we didn't even have the same conversations with our providers about when to seek treatment or if there were even options for us. So we have to just be aware of that.
So I know that I used to hear, and this is something that affected me on my own infertility journey. I heard that Black women in particular were super, like it was easier for us to get pregnant.
Right.
And that made it hard for me because I felt like I was not regularly working with infertility, but I was super pregnant because I was supposed to be extra pregnant. That's something that you have heard people say in your practice.
And that's what's been so hard. First of all, I want to say that you're breaking up a little bit. I could hear your question, but it's kind of going in and out a little bit. But I could hear, I believe you asked, just the hyperfertile myth that we've all just been labeled with as Black women. And so it really just starts from the initial campaigns for infertility awareness where we weren't seen in the ads, we weren't included in the conversation. And a lot of times there's the portrayal of a lower income woman with many children.
Yes.
She needs birth control. She doesn't need fertility treatment. She needs to have her tubes tied or go and get help to stop having babies. And it's just false and it's a myth. But we have bought into that within our community and even providers. So if a physician has that bias, whether it's conscious or subconscious, if they see a minority woman who's having trouble getting pregnant, they're going to view her situation differently and say, but I see so many Black women who can get pregnant. Just keep on trying. You'll be fine. you have babies just fine, and so no need to refer you right away. And so it can change the referral patterns. It can change how often women get access to treatment if their physician doesn't even think that they should be seen. And then even within our community, if we feel that way about ourselves, or we look around and we see women who are getting pregnant seemingly easily, we don't know what they've done to get pregnant, but if we believe that, then it makes us ashamed, embarrassed, or we feel like I must be the only one. We are super fertile. It's just me. I'm being punished, or I'm the only person in this church who is having trouble getting pregnant. We know that that's not true, but we buy into these stereotypes, and it just really, all those things come together to keep us away from the care that we deserve and that we need.
So, Dr. McCarthy, is it easier hearing now? Am I
it's still breaking up just a little bit.
Okay. All right. So, Kristen, if you could, I'm getting a little bit of feedback over here as well. So, can you tell me if those are the similar issues that you've seen, for instance, with Spanish speakers or people who are not native English speakers, and also people who are a part of the disabled or differently able community?
I think that, women who are, you have non-English speaking, or depending on where they're getting their care, they also might be just discounted in their fertility struggles. They may not get the same attention or the same amount of time to address those issues, depending on where they're going. If they're going to a clinic, maybe like a community health center, or a place where they're more focused on family planning and some of the general care, then they may not really have those conversations or access to the specialized treatments that they need also, just because of those limitations.
So if a family is coming in and they are, let's say, African American, low income, non-native English speaking, disabled, differently abled, if they are concerned about not having conceived after a period of time, what are some first steps that they can do to ensure that they get access to the care that they need to make informed decisions about their fertility?
I mean, the good news is that it's a basic conversation that can really start with a primary care provider, whether it's, their OBGYN or their internal medicine doctor, even their family practitioner. It's a very easy conversation to just say, I'm having trouble getting pregnant. I've been trying for a year, haven't gotten pregnant, or I'm thinking about getting pregnant in the future. What is my fertility? Those are conversations that can be initiated by a general practitioner, or a patient can bring that up. And so it's important for providers to be aware of, the basic workup. And if a provider is not comfortable and says that's outside my area, to have people they can refer to. And we all get referrals all the time from providers who say this patient just needs an infertility evaluation, and we're happy to see them.
Okay. And so are you aware of any additional supports that may be available to help families that are disadvantaged for one reason or another? I know financial resources are a major barrier that prevent many people from even beginning that conversation, because they perceive that they won't be able to afford treatment, and so they don't even show up for a diagnosis. So that's one barrier of perception and okay. If you could please turn your speaker down, just tweak.
Me?
Mm-hmm.
Turn the speaker down?
Mm-hmm. Just the volume down, just a tweak. So what are some of the other, so for people who are, so I know that talking to your doctor is easy if you have a relationship with your doctor, but I have also heard many people say that their doctors have kind of blown them off and said, well, just wait a little bit longer. It's been a year. Well, give it some more time. If your family doesn't have any history of this. So if people wanted to pursue support on their own, what are some things that they can do to try and access care outside of that direct route through their physician, if they feel like their physician is kind of interfering with their ability to get the care that they need?
Well, one thing that's great about what we're doing right now is that we're increasing the awareness and educating your viewers and everyone who's listening to us right now. So patients have to be their own advocate also. So
Yes.
it's great if you go and your provider initiates that whole conversation, but if they don't, then you have to talk to them and say, I am interested in my fertility, and you start asking those questions. There are lots of resources online now, thankfully. There are many reliable resources. You still have to be careful and not believe everything you read and everything you click on the internet.
Right.
But there are very good resources, including the Cade Foundation. We have a lot of information through our website, which is shadygrowfertility.com. That's just general basic information about fertility. So even if your provider is not providing that referral or bringing that conversation up, you can start arming yourself with the basics of, if I've been trying for 6 to 12 months and haven't gotten pregnant, I want to talk to someone about it. And if you're not getting those answers or not satisfied with the response that you're getting from your provider, then you have to go a step further and pursue that with someone else.
So are you aware of any kind of general websites where people can go to learn about available local resources? And I'm thinking about places that are maybe geographically isolated. If they're in Georgia, but they're out deep in the country, hours from a major city, is there a place where they can learn about at least, where's the closest clinic that would be able to evaluate me for this if I don't feel comfortable talking with my doctor for whatever reason?
I don't know of a direct site where you can go and say, this is where, particular resources like that are. But if you start with a search for just your area, we're in Atlanta. So if you say fertility clinics in Atlanta, you're going to get the practices that are here. You can look at different practices and see what their culture is for their practice, what they offer, what their expertise is. There are patient support organizations like Resolve is a national organization that provides lots of resources for patients, and that can also be a link to more local resources.
That's outstanding. So do you all have any programs at Shady Grove? I know Dr. Desiree McCarthy here, medical director for Shady Grove in the Atlanta metro area, or in the state of Georgia. And I'm wondering if you all have any programs that would make fertility treatment more affordable for lower income families to address that very important barrier of cost.
We do. We actually have several financial programs. We have a program that's called Shared Help, which is a discount program. We also offer discounts to active duty military. One of the programs we have that is very popular is that we offer money back guarantee for many of our treatments, whether it's doing IVF or donor eggs or those type of treatments. We have a program that's called Shared Risk, where what if a patient qualifies, and we have to make sure that her uterus is healthy, egg reserve, sperm counts are normal to qualify for those programs. And if a couple or patient qualifies for those, you go through your treatment, and if you do not have a baby at the completion of your treatment, we give you a full refund for that one. So that can also help to just offset some of the anxiety that patients feel, where they feel like this is a very big investment that we're making in our treatment. And you can go into it with a little bit more reassurance that, the first goal is always to have a successful treatment and to have a baby. But if we put all of our resources into this treatment, and for various reasons, if we still do not have a baby at the end, we're comfortable that at least we get our money back for that one. So that's been helpful for a lot of patients who come to Shady Grove.
Okay, that's great. So for people who are very new to this, have no background in what infertility treatment is, can you give us a little overview of what they may be looking at from a testing standpoint, from a physical exam standpoint, and from a cost standpoint?
I always break it down when I see a couple who's been trying to get pregnant, and we say infertility for a woman who's under 35 is if she's had regular unprotected intercourse for at least 12 consecutive months. That's the definition of infertility, time to see a specialist. Once a woman's 35 or older, then we shorten that to 6 months of unprotected intercourse, and then it's time to get an evaluation. And when it's time for the evaluation, it always comes down to sperm, eggs, and anatomy, and that's what we look at. So if there is a male partner present, he needs a semen analysis. It does not matter if he has children before, or if he's had a normal semen analysis in the past. Men make new sperm every couple of months. So we always want to do a current evaluation to make sure his sperm count is fine. And we do that from the beginning. We don't go through a full female evaluation and then look for a male factor if we don't find anything else. That is a crucial part of any evaluation for a couple, is to do a semen analysis for the male partner. And then the rest of the testing is going to be for the female partner. So egg reserve, we do ultrasound at the beginning of the menstrual cycle around day 3. Okay. That's the best time. Day 1 is when the period starts. So a few days in, we do a vaginal ultrasound. We can look at the ovaries and count how many little follicles or eggs are developing, and that gives an idea about the activity of the ovaries. Okay. We do blood testing for a hormone called FSH, which is follicle stimulating hormone. That's a brain hormone telling a follicle, egg, and the ovary to develop. So we can look at that number. Should be less than 10 when the egg reserve is healthy. And then we measure another hormone called AMH, or anti-mullerian hormone. That's a hormone that the follicles or developing eggs in the ovary produce. So an AMH level is normally going to be between 1 to 4. As our egg reserve naturally goes down, your AMH goes down. For many women with overactive or polycystic ovaries, the AMH can be higher than normal. So that's basic egg reserve testing that we do for all women. When it comes to reserve, we also have to consider those numbers in the context of the woman's age. And so we know that for ladies, very different from men, our fertility is changing as we get older. Men make brand new sperm every couple of months, but we are born with all the eggs we'll have. And so from birth on, our egg reserve is slowly declining, and the decline starts to pick up by mid-30s, and especially by 40, egg count drops more dramatically. The eggs that we still carry are aging as we are, so the quality of those eggs starts to change. So when you look at the AMH and FSH, they mean something different based on the woman's age. So age is also a big factor. And then the third piece is anatomy. So egg, sperm, and anatomy. So when it comes to anatomy, we do ultrasound to look at the uterus, make sure it looks normal, no fibroids or abnormalities. And then you want to make sure that the fallopian tubes are open. So we do an X-ray test called an HSG, flush dye through the uterus and tubes and make sure the tubes are open and there's no blockage to keep sperm and egg from getting together. So that's the basic assessment for a couple who's having infertility.
So a vaginal ultrasound and an HSG are the two physical examination tests for women. And then we talked about the FSH and the AMH test. Yes. You know, would you recommend that all women look at their FSH and AMH if they get to a certain age, and even if they're not actively trying to conceive, just so they have an idea about where the fertility is?
It's a little bit tricky, especially with the FSH. So the main reason to check an FSH, or the basis for when we first started looking at FSH, was to get an idea about if we were doing fertility treatment for a woman, how likely did we expect her ovaries to respond, how much medication should we prescribe, and things like that. So that's what the FSH is most useful for. It doesn't exactly say if my FSH is this number, then I have this % chance of getting pregnant, because we've seen women with high FSHs get pregnant. We've seen women with normal range FSHs who have had trouble getting pregnant. The AMH is an easier test to check on than the FSH because it's not dependent on a woman's cycle. So yes, an AMH is a very easy test for a woman if she's going in for an annual exam or just says, I want to just check on my egg reserve. You can do an AMH blood test any day in the cycle, even if a woman's on birth control pills, and that's just kind of a snapshot of what the egg reserve is. So I think that that's a helpful test. That's pretty easy to check. The FSH, again, you have to look at on day 3 of the cycle. So that one's a little bit harder to catch based on when a woman's in her cycle and might require an extra visit or things like that. But an AMH is very easy to just check on.
Got it. Okay, so this is really good so far. And then cost. Can you tell me if these are not covered? I don't, for instance, in Georgia, I don't believe that fertility testing and treatment is covered by medical insurance.
Right.
So how much do these laboratory tests and physical exams tend to cost?
So it's a little bit tricky here in Georgia since we're not mandated. So probably 50 to 60% of the patients we see here have insurance coverage, which means that the remainder are out of pocket. If they're out of pocket for the hormone testing, will be a couple $100 to do that, and ultrasound is going to be about $300. HSG is going to be around $700. A semen analysis is about $150 out of pocket. If patients have insurance, even if they don't have infertility coverage, they might have GYN or diagnostic coverage with their plan. That would still cover the basic testing. And then if they don't have fertility coverage, then fertility treatments may be out of pocket. But we still see many patients who may at least be able to get their initial testing covered by insurance before they have to go out of pocket when they get to the actual treatment themselves.
So when you added all those numbers together, what I heard was more or less around $1,000 for
that
initial testing. And then, there may be some partial coverage, even in states that don't have mandated coverage, there still may be some partial or complete coverage for fertility care, depending on who the employer is, things of that nature. Okay, great. And so I think we are kind of getting close to the end. We've got 3 minutes left. So if you had any parting words to share to an individual or a family that was disadvantaged, again, if it was because of where they live, if it was an African-American family, a Spanish-speaking family, a family that had one or both parties that were disabled or differently able, what would you share with them?
So the basic things I want all couples to think about is just think about your fertility. Don't try to fit into the box of what you think the fertility patient looks like and say, I don't look like them, so I'm not going to pursue this. If you've been trying to get pregnant for 6 to 12 months and you haven't been successful, then seek out treatment. Start with your primary provider. Go online, look for fertility clinics in your area. If you know that you have a fertility factor already, if you've had pelvic infections, you have a damaged tube, you have fibroids, you've had trouble getting pregnant with another partner, you have irregular cycles that might be a sign you're not ovulating, don't ignore those things and go ahead and seek treatment earlier. For women, we have to think about our timeline. And we know that as we get into our 30s and 40s, our fertility is changing a lot. So don't wait. Get to the fertility treatments when you still have a better chance of being successful with those. I'll just mention for African American women, we do have unique fertility factors, whether it's our age, our duration of infertility. We usually wait longer before we see a fertility specialist, so we're older when we get there, and that can be a disadvantage. We're more likely to have uterine fibroids, and we know that those can impact fertility treatments and pregnancy outcomes. We're more likely to have blocked tubes from pelvic infections, tubal ligation, and things like that. And then our weight is the other factor that we see more commonly in African American women. We're more likely to be overweight or obese in the U.S. population, and that can affect our fertility, our pregnancy outcomes, and all. So those are things that we have to think about and see if we have any of those risk factors, address the ones that we can, and seek treatment, while we still have a chance to be successful.
Awesome. Well, this has been really illuminating. I know that I've learned a lot, and I hope that everyone else has. So thank you so much again, Dr. Desiree McCarthy-Keith, Medical Director at Shady Grove Fertility in Atlanta Metro, but we are for all of Georgia. And I appreciate her time. And for those of you who are watching, I appreciate you spending your lunch break with us. And then I will end with our catchphrase of what's in your cup. So Dr. McCarthy, what's in your cup?
Water.
Water. Awesome.
Lots of water.
And I'm drinking water now, but earlier today I had a chai latte. So I'm chasing that with some water. So stay on the line for 1 second. I'm going to close us down. Thank you guys for joining us. If you have any questions, feel free to post, and I'll do my best to answer. If I can, I will ask Dr. McCarthy-Keith to share her response to your questions. Have a fantastic Monday. And
thank you so much. I just want to say thank you for just giving me the opportunity to be here. It's always my pleasure to speak with you, and I just appreciate everything you're doing.
Thank you. Thank you.
My pleasure.
Hold 1 second.